is osteoporosis? Well, the World Health Organization describes it as a progressive and systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. This is a great diagnosis, great description of the diagnosis of osteoporosis. And this photo that I have here, I think, is a really good visual. This is basically a cross section of a femur bone, and you can see the difference between the thickness of the cortex and the integrity of like the trabecula, which is this kind of like webbing on the inside, versus somebody who unfortunately has osteoporosis. So you can imagine that somebody who has this bone is much more able to withstand a fracture than somebody like this with low energy trauma. And unfortunately, sometimes it even happens with no trauma. So the prevalence of osteoporosis in general, 1.5 million osteoporotic fractures occur annually in the United States. There's estimated 10 million people with osteoporosis and 35 million people who have low bone density. So low bone density is basically osteopenia. So osteopenia is the precursor to osteoporosis. So I may use those terms interchangeably. So this is a diagram that I keep in the office, and I find it extremely helpful so that when I'm explaining to my patients what exactly is going on a cellular level, this is basically the gist of it. And this is not just cancer and cancer treatment. This is across the spectrum with bone changes in general, whether they're medically induced, whether they're induced by multiple medical comorbidities, but this is the gist of what's going on. So these octopus-looking guys, these are called the osteoclasts, and these are the cells that basically are responsible for breaking down the bone, which is normal. I always use the example, our skin is constantly shedding and regenerating and rebuilding. Our bones are the same. Remember that our bones are meant to be dynamic. They're not meant to be in a state of stasis. So this is very important to understand the phases of bone removal. These are the common risk factors that are associated with bone loss in oncology. So obviously it's impossible for me to go over every type of cancer that exists or all types of remedies that exist for it, but these are going to be like the main culprits. So the aromatase inhibitors are geared towards the patients who have estrogen positive breast cancer. And, you can get it in patients who are either postmenopausal or medically induced menopause. Or if they're premenopausal, they're found to have breast cancer and they go on tamoxifen, then it can increase the risk of having further bone loss. So in general, they say it's about 35 to 55% increased risk of fracture with these treatments, and that it's common to have about 4 to 5% of bone loss over the next 2 years. Androgen deprivation therapy typically is used in patients with prostate cancer, and it can cause about the same amount of rate of bone loss, between 4 to 5% per year. Again, also increases the risk of fractures. Chemotherapy-induced premature ovarian failure, again, for the younger patients who go into menopause because of these chemotherapeutics. And any type of abrupt loss in estrogen or in men in testosterone can increase the function of the cells that break down bone. So then the cells that build bone, going back to that diagram that we were discussing, they do increase the risk of that. And the cells that build bone have a little bit more of a difficult time with rebuilding and keeping up with the work. Let's see. Slide. Okay, other common treatments, glucocorticoids, pretty common in lymphoma type regimens. It blocks the calcium absorption. It increases the risk of a fracture. I didn't put it on the slide, but basically it can significantly decrease the quality of the bone. So as we're going through the phases of remodeling, we also want to make sure that we are building high quality bone, and some of these remedies unfortunately don't allow that to happen. Stem cell transplantation, sometimes the body irradiation, the high dose chemotherapeutics, immunosuppressants. The highest risk of having bone loss is usually within the first year. Radiation therapy can cause localized bone damage. I know that they try extremely hard to try to avoid damage to any of the other surrounding structures. Sometimes it's completely unavoidable though, and you can have that local bone damage there. And then because of the damaged structures behind it, you can have insufficiency fractures of those areas. And then the GnRH agonist, they chemically reduce, estrogen and testosterone. They use it in both genders, and it can also cause rapid acceleration of bone loss. So then how do you find out if you have osteoporosis or osteopenia? Well, the gold standard right now is the DEXA, which is the dual energy X-ray absorptiometry test. It is a diagnostic tool. It's not the only indicator of having low bone mass or bone loss. It tells me the quantity of the bone, but it doesn't tell me the quality of the bone. It's in patients who have a history of fracture, especially low energy fractures. I don't necessarily need a bone density to tell me that you have osteoporosis or poor bone quality, a high risk of fracture. It's not a perfect test. So if there's anybody who has arthritis, like specifically arthritis in the spine is usually like the most common area. It doesn't differentiate between arthritic bone and dense bone versus somebody who has normal bone. So it's not a perfect test. There are variations between the different machines. I always tell my patients, make sure that once you get your bone density, you're going back to the same machine every single time. These machines, they have a built-in memory. And even though we have multiple locations across Baptist Health that offer this test, the machines between themselves, they don't communicate. So you want to try to make sure that you are going back to the same facility with the same machine. What it does is that it pulls up the profile of the last time the bone density was done on the specific patient, and they're able to do an accurate map out, which is kind of like what's depicted here on the right. So I do want to make sure that that's emphasized, that you do want to make sure that you do it on the same machine every time. It is dependent on the radiology technologist for accuracy. And we do need it to calculate a FRAX score. And I'm going to get into what a FRAX means in just a second. So basically, the bone density is going to tell me what the T-score is. And the T-score is basically their standard deviation points, right? So 0 being the normal bone, they do a comparison between the patient's bone density versus somebody who has the ideal perfect skeleton, which happens to be a 20-year-old female. Even males are compared to a 20-year-old female because they are said to have the ideal perfect skeleton. Of course, 20-year-old is going to have better everything, right? So basically, like I said, 0 is normal, and anything that's further away from 0 is going to indicate the severity. So typically, osteoporosis begins at -2.5, and severe osteoporosis is at -3 and below. So these are the patients that we're concerned about, that they have the highest risk of fracture. Okay, so this is the FRAX calculator. So this is basically a calculation tool that tells us what the 10-year prediction risk is of having a fracture. And as you can see, the information that it requests is very basic. Tells you, it asks where do you live, where are you from, the age, gender, height, weight, history of fracture, did mom or dad have a history of fracture, smoking, steroid use, etc. So you plug in this very basic information, then it spits out a calculation and it says that there's this percentage risk of having a fracture in 10 years. So if you have a 20% risk or higher risk of having a major osteoporotic fracture, that means that you have a high risk of fracture and that you should go on treatment. If it's 3% or higher risk of having a hip fracture, then it's recommended that you go on treatment because you have a high risk of having a hip fracture. Now, basically, the reason why they have two separate scores is because the hip fracture morbidity and mortality rate is much higher than versus everywhere else having a fracture. Major osteoporotic fracture could be the spine, could be the wrist, could be the shoulder, right? But the hip fracture is calculated separately because of that reason. So these are the areas that are considered the low energy fracture sites. So if anybody has had any fractures in these areas, then they, by having low energy, meaning less than 3 feet in elevation, then that means that you do have a high risk of having future fractures. Anybody whose T-score is less than -2.5, then it is recommended for you to go on treatment. And then T-score of -1, which is osteopenia or low bone mass with a high risk of fracture. So let's say somebody who has the lowest T-score is -1.5, but they have a 30% risk of having a major osteoporotic fracture. That's an indication for treatment itself. Okay, so now that we talked about all those ugly things that could happen, let's talk about ways to avoid them. So we know that with bone health, nutrition is absolutely critical, and I am going to talk about exercise as well later on. We know that, 99% of the calcium is stored in the bone. It is stored as calcium phosphorus hydroxyapatite crystals. So that's the storage, right? That's the storage center for calcium. And we need calcium for regular bodily functions, for muscle contraction, for heart contraction, etc. So we want to make sure that there is good homeostasis of calcium in the blood. So basically, if for whatever reason, you have a drop in your calcium level, well, then calcium is going to get pulled out of the bone in order to maintain the equilibrium of calcium in the blood. It is recommended in most cases, and there are specific cases that if you have elevated levels of calcium, obviously you don't want to supplement. But you do want to try to get an average of 1,000 to 1,200 milligrams of calcium per day. And ideally, you want to get it from food. You don't want to get it from a synthetic calcium supplement. More and more, they're coming out with information showing that synthetic calcium supplements can cause issues with the coronary arteries. So I only recommend food as an option. There are very rare, very specific type of patients that require synthetic calcium supplementation. That's a separate issue, but most cases you always want to try to get it from food. So then there's an example of different foods that you can take to try to increase the amount of calcium intake in your diet. Vitamin D is another one. This is kind of like a hot topic. A lot of people are doing research on vitamin D. The reality is that we don't have a clear target. In general, most people who do bone health can agree that you want to try to have at least 60 nanograms per milliliter of vitamin D in your blood. So between 50 and 60 is considered acceptable. Anything below that is kind of what I would call insufficient in order to support bone health. There are direct, vitamin D deficiency can cause an increase in parathyroid hormone, which is the hormone that's responsible for pulling the calcium out of the bone. So you want to make sure that you have adequate levels of vitamin D so that you're supporting your bone health and making sure that you're not getting it pulled from the bone. People who have who are indoors or who do any type of like limited sun exposure, they have obviously more risk for having a vitamin D deficiency. And it can cause, even either fractures or bone stress injuries, things like that. And these are areas where you can get it. So the sunlight, what it does is that it actually activates the vitamin D. So it's not that it's a direct source of vitamin D, but you do want to get it in order to activate the vitamin D through your skin cells. Protein is also very important. We do have protein in our bones. It's usually like in the form of collagen, but as it is protein, you want to try to support it. You want to try to support your protein intake I'm sorry, you want to support your muscle mass by having adequate amounts of protein. And approximately 50% of bone mass is based out of protein. It's about a third of the mass. You want to try to get at least 75 to 1 grams of kilograms. I'm sorry, 70.75 to 1 grams of kilograms of body weight of protein per day. And this is something here. IGF-1 is it's an anabolic agent. It's like a hormone in our body, but it basically has like a bone building effect. So you want to make sure that you are getting adequate protein because it also stimulates bone growth. And obviously, we need it for muscle synthesis. And if you have good muscle tone, it can lower the risk of having fractures. If you have small muscles plus weak bones, there's a very, very high chance of having a fracture. And of course, you can get protein from these sources here. These are additional nutrients. I don't particularly recommend supplementing any of these, but we do know that they are important elements for maintaining bone support. But there's not enough studies to say you need X amount of, milligrams of magnesium in order to support bone. But if you have a magnesium deficiency, of course, you do want to supplement it. If you have a zinc deficiency, of course, you want to supplement it. And these are all things that I normally check when I'm doing a workup. Okay, so the benefits of exercise on bone health. We know that as you exercise, it causes an expansion of the endocortical aspect of the bone. So if you can follow me here a little bit. So this is somebody who's bone formation. This is somebody who does not exercise, right? So this ring here represents exercise, or I'm sorry, new bone that's being formed. But you can see that there's not like that added benefit of somebody who has been doing exercise. When you do exercise, there's an extra layer of bone that's being created because you're stimulating the phases of bone remodeling to occur. So then somebody as they're aging, you can see that it has that extra protective effect of protection onto the bone and actual additional bone growth. So once you stop exercising, though, the benefits on the bone are no longer. So you do want to make sure that you are exercising throughout the lifetime. So the type of exercises that you want to do, you want to try to do resistance training is really the most important thing. And there's some sports here if anybody is participating in any sports. We know that swimming, walking, cycling, they're not very good about building bone. You want to do resistance exercise, or you want to try to do like things, pickleball is a huge thing, right? And where you have to kind of like go from side to side and stop and pivot and do things like that so that you can stimulate bone growth. But typically, you want to try to do about 15 minutes, 5 times a week of exercise, specifically strengthening exercise. It could be with weights, it could be with body weights, it could be with resistance bands. And we know that the multi-directional loading has the most benefit to increasing bone mass. You obviously want to do things like cardio exercise, whether it's the swimming or the walking. You want to try to maintain a nice core because you want to decrease the risk of having falls. No falls, no fractures, right? So after you get to skeletal maturity, with, women, it's about age, 15, 16, and men, it's about 18, 19. You do have gains in your bone mineral density, but it is much less. And then not exercising can offset the bone mineral density benefits. So there is a high prevalence of osteoporosis. It is underscreened and underdiagnosed. Most people are very good about being on top of it, and especially, the oncologists that they see these patients frequently and that they are that they're prescribing these remedies. They do a nice job at getting the bone densities and referring out whenever appropriate. If you do have a diagnosis of osteoporosis, it is a lifelong diagnosis, similar to diabetics. If you have diabetes, you know that if you don't take care of the things that you eat, then you can go back to having it. So it is reversible, though, with treatment and lifestyle modifications. I have had patients that, they're in like the osteoporosis range, typically like early osteoporosis, -2.5, -2.6, and they are able to improve their bone density by exercising, by having the adequate amount of calcium intake. So it is important to know that it is reversible. Exercise and nutrition does have a direct impact on bone density, and of course, anything will help lower the risk of having fractures. Thank you very much. Hopefully I allowed some time for questions.
Thank you so much, April. Let me just turn on my video back on again. Opening the floor to any questions. Does anyone have any questions in the chat, or feel free to unmute yourselves? One moment. Right, so I have a couple of questions that were sent over to me, and we'll get started with those then. And again, if anyone has any questions, feel free to enter. So first question I received is, do people who follow a vegetarian or vegan diet face a high risk of bone loss?
Yes, absolutely. So we do know that is one of the risk factors and it's not so much. So basically, we know that the amino acids, which are the building blocks of protein, they're a little bit more available in, animal products, meat, fish, chicken, whatever. It's more difficult to get the quantity of protein through having a vegan or vegetarian diet. And like I said, muscle mass and bone mass are very closely linked. So if you have small muscles, then that increases the risk of having fracture or having low bone mass. So that's really what it is. So it's not like a direct impact. In that way, it's more of an indirect impact because of the risk of having, smaller muscle mass.
Okay, thank you. Another question I also received is there a specific age I should seek a DXI test?
So it depends. And as it relates to, so on patients who are not on any of these oncology medications or treatments, the right now the guidelines say that you should get a bone density for females at 65 and older, and for males 70 and older. There's a lot of argument to that though, and I see it on a daily basis. Sometimes I have patients in their early 60s and they already have severe osteoporosis. And bone loss is multifactorial, right? So it can be caused by several reasons. It could be that, you had a lactose intolerance or a milk protein allergy, so you didn't get enough calcium growing up as a child. Maybe you didn't get enough outdoor play. So all of these things add to what we call your bone bank, which is what I would like to refer to as like the retirement account, right? So you want to try to build your peak bone mass. And that's typically done at an early age, like in your 30s. Once you hit 30, everybody, men and women, they can start having a decline in their bone mass. So, right now the guidelines say, and insurance obviously is a big deal, right? Because they're the ones who kind of dictate when this can be done. But if you have, say, for example, a family history of osteoporosis, if mom or dad has suffered a hip fracture, or if you have known history of like vitamin D deficiency or things like that, I would definitely say that you should get it done much sooner than what the guidelines say to do it. Or if you have a history of long-term steroid use or any of these chemotherapeutic agents or hormone modifiers.
Great, thank you. We also had a question on is there any way you could talk a little bit about bone loss in teeth after proton radiation in the head and neck?
So again, usually radiation can cause localized damage. If it depends on where it is, right? They do try to target the area of concern and they try to minimize any damage to the surrounding tissues. Um, my understanding is that they have advanced quite a bit in that field. The only thing that I would say is that there could be just some local damage to the surrounding tissues, like the bone structures around it. If there is a concern or if there's any pain, especially like in the neck area that was, being questioned, if there's any discomfort there, I would start by getting an X-ray. And even X-rays, you can see bone loss. There are some radiologists who are able to determine that there has been bone loss based on just having a plain X-ray.
Thanks, April. And another question that we also received was, are there online resources to learn more about the best source for calcium and the other vitamins and materials mentioned today?
Can you repeat the question? I'm sorry.
Yes, of course. So, are there online resources to learn about the best source for calcium and the other vitamins and minerals mentioned today?
Yeah, in general, you can refer to the Bone Health and Osteoporosis Foundation website. They have a very nice like patient section that talks about different exercises that you can do, calcium intake, recipes to try to increase your calcium intake and vitamin D. I find that website to be the most comprehensive. I refer to it quite a bit for my patients. The International Osteoporosis Foundation is another one. But yeah, those are the websites that I would say are the most helpful and are probably the most comprehensive.
Okay, and another question we also received is I'm interested on last findings on flexion of spine during exercising. Is it contraindicated?
So typically patients who are found to have osteoporosis, so if I can go back to the slide that has the T-scores, right? So patients who have osteoporosis, so T-scores that are in the -2.5 or below, even if one site, let's just say they check, they usually check both hips and they check the spine, right? When they're checking a bone density test. So if somebody comes back with a -3, right, in their left hip, you can assume that -3 is everywhere. It applies to the whole skeleton. So then the risk of having fracture is everywhere. And unfortunately I do see it. So let's just say somebody who has a score of -3 in the hip, and God forbid they sustain a low energy fall or a ground level trip and fall, they can have a wrist fracture, right? They can have a proximal humerus fracture or a shoulder fracture. So, as far as like avoiding, the number one thing I would say, of course, is don't fall, right? But you want to try to avoid, like, let's just say the spine was the question, right? So I always tell patients that you want to avoid doing any type of twisting injuries. So like if you're doing, let's just say mat Pilates, right? And they make you do the Russian twist where you're kind of going from side to side. You want to avoid moves like that. You want to avoid any type of direct axial pressure. So I would say you would want to avoid sit-ups or crunches or things like that. Because you can ultimately increase the risk of having fracture because you're putting kind of like that irregular pressure on the spine.
Another question we received is, can you elaborate on Zometa IV infusion benefits and risks for post-breast cancer treatment? How common is the side effect of jaw osteonecrosis?
That's a great question. Good. I'm glad you asked that one. Okay, so Zometa, it is a bone, it's an anti-remodeling agent. So if I can go back to my little doodle, this one. So if you're looking at the phases of bone remodeling, the treatments that we use for osteoporosis or to optimize bone health, I say we're two trick ponies, right? We can either decrease the function of the cells that break down bone, or we can increase the volume of the osteoblasts, which are the bone building cells. So Zometa and Xgeva or Prolia or Reclast, those are medications that work on this side. So basically, Zometa, what it does is that it actually kills this generation of cells. So it will get rid of the osteoclasts and all of the precursor cells. So then these guys, the osteoblasts, they have more opportunity to try to rebuild the gaps that are there, right? So the benefits of it, especially like in breast cancer patients, specifically estrogen positive breast cancer patients, there have been recent studies that show that it can decrease the risk of progression of bone loss, right? So if you have osteopenia, hopefully it decreases the risk of progression to osteoporosis. We know that it can decrease the risk of having bone metastasis if it's not already present. If there is bone metastasis present, then it can help decrease the progression of it. Patients who are kind of like on aromatase inhibitors, for example, like letrozole and anastrozole, and they have had bone loss noted, sometimes the oncologist will order a Zometa infusions every 3 to 6 months or whatever, and that also has the benefit of decreasing the reoccurrence of breast cancer. These are not astronomical, numbers that we're talking about, but of course, most people who have gone through this, everything helps, right? So like the aromatase inhibitors, like the anastrozole and the letrozole will lower the risk of having breast cancer reoccurrence. This is kind of like the cherry on top. Now, as it relates to the risk of osteonecrosis of the jaw, now if you're getting Zometa infusions frequently, again every 3 to 6 months, the risk of osteonecrosis of the jaw definitely increases. I use the zoledronic acid, which is the generic version of Zometa, but the way that we use it in osteoporosis is they get the infusion only once a year. Zometa is given every 3 to 6 months, right? So then the risk of osteonecrosis of the jaw is much higher because of the frequency of the dosing. But there, again, are very specific indications for it. So people who have, unfortunately, osteoporosis because these remedies for cancer provoked it, or if they had pre-existing osteoporosis prior to starting these treatments, or if there's a presence of bone metastasis, you definitely want to, stay on the treatment if it's recommended. And I believe the risk of osteonecrosis of the jaw is estimated to be around 30%. Also, I do want to define what osteonecrosis of the jaw is because some people may not know what that is. So osteonecrosis of the jaw is a very ugly name, and basically what that means is that you can have, like breakdown of like the gum area, and you can have exposed bone, and it is a very annoying side effect that can happen. And there are remedies that can occur that can try to decrease the risk of it, or there's treatments that if there is osteonecrosis of the jaw that exists that can help kind of reverse that osteonecrosis of the jaw. But yeah, it's something that happens with Zometa infusions, depending on the duration and the frequency, of course.
Okay, and another question that we received today is what can I do to manage bone pain when receiving chemo treatment?
I guess it really depends on the kind of chemo treatment that's being prescribed. You do what you can, obviously, to try to stay as comfortable as possible. If they have to pre-medicate with Tylenol, I would probably defer that question to the oncologist. I think I have heard that maybe like Claritin has also helped to decrease kind of like that, like acute phase reaction that can happen. But yeah, I would just, hydration is another thing that's absolutely critical too. That can hopefully maybe decrease the risk of having those effects.
And another question that I received is considering how menopause is linked to osteoporosis, and menopause can be caused or started early by cancer treatment. Would you mind going over how those two risk factors can be linked?
Yeah, so we need estrogen in our bodies in order for the osteoblast to be effective, which are the bone building cells. And then the lack of estrogen can increase the function of the cells that absorb bone. So yeah, it's something that we know that whenever there is a lack of estrogen, whether it occurs naturally through menopause or if it's induced by oncology medications, then we know that the risk of having bone loss is there. Same thing, you want to try to have proper amount of calcium intake, 1,000 to 1,200 milligrams. You want to make sure that your vitamin D levels are between, 60 to 70 nanograms per deciliter. You want to try to make sure that, if you have the energy to, you want to try to do strengthening exercises specifically. Strength, like I said, resistance, strengthening exercises, weights, resistance bands, body weights, anything like that is going to help kind of stimulate and force these osteoblasts to work a little bit better.
Okay, thanks, April. And I'm going to open the floor again. I didn't see any more questions in the chat. Does anyone have any questions that they can unmute themselves or put in the chat? Anyone else? I'll just give a moment for that in case there's any additional questions.
Could you repeat the name of the website, the first one that
Yes,
that was recommended? Thank
yes,
you.
it's the Bone Health and Osteoporosis Foundation, BHOF. And then the other one is the International Osteoporosis Foundation, or the IOF.
Thank you. Thank you.
Of course.
Right, so it looks like I don't have any other additional questions. Thank you so much for sharing again those two resources. I was actually going to ask about that, so that's great.
Actually, April, if I do have a question,
Yes.
real fast. I'm a 58-year-old man with androgen deprivation therapy,
Mhm.
and I had a hip replacement because I did have the cancer in my femur and in my hip. And I used to love to roller skate and to bike, but I haven't, of course, since all this has happened. Should I stay away from those completely?
Well, you want to stay away from falling, right? So,
Yes.
you try to be as safe as possible. If you haven't, if you've had these surgeries and your orthopedic surgeon has cleared you to go ahead and resume activities,
Mhm.
then you can start to do like a gradual increase. So, like whether you're doing stationary bike in the hopes of trying to do it in an area, and obviously stay away from traffic. Try to be safe about it is what I would say, and obviously making sure that you do get cleared from the operating surgeon
Yes.
before resuming any of those activities. Um, I didn't catch your age at the beginning though.
I'm 58.
50. Yeah, okay. So if you're on that, make sure that you have a bone density, that's current and that you're keeping track of it. But yeah, you do want to try to increase, like I said, specifically resistance training. That's the most ideal. Of
Perfect. Thank you.
course.
Okay. And Julianne, I saw that you went to unmute yourself. Did you have a question?
No, I'm good, Aaron.
Great. Thank you. All right. So, anyone else, any last minute questions? Good. All right. Well, thank you so much, April. This is such an important topic, and it was a pleasure having you. And again, thank you to Baptist Health Cancer Care. They're amazing partners. We really appreciate everything that all the doctors and nurse practitioners that they've provided and the resources. And with that, again, thank you so much, everyone, for attending. This will be on our YouTube channel shortly. And if you have any questions, if you're looking for any resources or connections to Baptist Health Cancer Care, just the YouTube link, feel free to reach out. And I'd be happy to provide those for you. All right. Have a great rest of your day, everyone. Take care.
Thank you. Thanks, Aaron. Thank April.
Thank you.